Hi there, my name is Shelby Burrows, and this is my disorder presentation from medical audiology. First, we're going to start today by reviewing the case history. We are presented with a 36-year-old female who was seen for an audiologic evaluation prior to beginning chemotherapy treatment for tonsillar cancer. At this time, there was no reported history of any audiologic or otologic involvement at that time. Moving on to the pre-chemotherapy audiologic test results. Otoscopy was completed and was unremarkable bilaterally. Hair and bone conduction thresholds were conducted and were within the normal hearing sensitivity range bilaterally. And word recognition was excellent bilaterally as well. The patient was seen at a later date again for post-chemotherapy test results, and again, otoscopy was unremarkable bilaterally. Air and bone conduction thresholds were normal from 250 to 2000 hertz. And then in those higher frequencies, we see a mild sensory neural hearing loss bilaterally. And so we're starting to see that trend of elevated thresholds in those higher frequencies. Word recognition in the right ear was good at 88% and was excellent in the left at 92%. Due to that decrease in hearing, the patient was seen for a medical examination where she presented with essentially normal otologic function. And so with everything in mind, what would your diagnosis be? And I know I kind of hinted at it a little bit earlier on with that case history. And so, if you said ototoxicity, you would be correct. As for audiologic recommendations and management, the results of the post-chemotherapy evaluation were reported to the oncologist, and the chemotherapy regimen that the patient was on was adjusted. The patient's hearing has since stabilized following that adjustment to the chemotherapy regimen, and her hearing continues to be monitored throughout the treatment. Alrighty, and as for medical recommendations and management, because the patient was seen prior and presented with essentially normal otologic function, the only medical recommendation that was made at this time was to continue audiologic monitoring. And again, just as a recap, as for patient follow-up, following that adjustment to the patient's chemotherapy regimen, the patient's hearing has since stabilized and she continues to be monitored throughout the rest of her treatments. Alrighty, so changing gears a bit, let's talk a little bit about ototoxicity. So, ototoxicity is a functional impairment and cellular degeneration of the tissues of the inner ear caused by therapeutic agents. The result of the exposure to these therapeutic agents causes a loss of hearing and or vestibular function. The most common ototoxic drugs include aminoglycoside antibiotics, platinum-based chemotherapeutic agents such as cisplatin and carboplatin that we hear about quite frequently, loop diuretics, macrolide antibiotics, and antimalarials. And so, aminoglycoside antibiotics and the platinum-based chemotherapeutic agents cause the most severe and irreversible hearing loss and can also cause severe nephrotoxicity. In a study performed by Landier 2016, he reported that the reported prevalence of ototoxicity in patients who received ototoxic therapy ranges widely from 4% all the way to 90%, depending on many factors such as the agent or agents that were used, the age of the patient population, the cumulative dose. So again, if they are taking more than one agent at a time, that cumulative dose together, how that affects the body, and then the administration technique. So whether the agents were presented to the body through intravenous injection, a pill, or any other sort of administration techniques that they may use. So as for standard of care, when reviewing the literature that is out there about ototoxicity monitoring and management, there seems to be a wide range of responses that have been made in the past. And so in this study by Maru and Malky 2018, the study was conducted in the UK. Physicians were surveyed on how they would respond to concerns from their patients regarding ototoxicity. And so these surveyed answers were broken down into several sub brackets, and these were some of the ones that I found most important to the case that I'm presenting on. So when it comes to medication modifications, 40% of physicians stated that they could not make any modifications to um, some of their patients' regimens, and whether that just be the particular type of cancer that they're trying to fight at this time, they just did not feel comfortable making any modifications. And that's fine. It's just something that we have to keep in mind when we are monitoring their hearing. As for other alternatives that were provided, they included a complete withdrawal of the therapeutic agent, a dosage change, so decreasing the dosage potentially, having a change of medication, so switching from one therapeutic agent to another to hopefully alleviate some of that ototoxicity that the patient's experiencing and causing that hearing loss, and then again, no alterations. When it comes to the improvement of hearing function, most physicians indicated that they would recommend amplification and or refer their patient on to audiology for any other sort of management, such as cochlear implants, Bajas, anything of that sort, if they found it medically okay. And then as for minimizing disability, the options that were recommended for their patients included assistive listening devices, home modifications, referral to an SLP, OT, and any other services that may be of benefit to help minimize the disability that that patient is now facing. And then as for 3 things that I learned, the first being that the risk factors for elevated hearing thresholds as a result of ototoxic medications include a high cumulative dose, pre-existing hearing loss, renal insufficiency, and others. And while it definitely makes sense now after doing this presentation and with some of the presentations that Dr. Seaman has presented with us, prior to this, I had not thought about how important our renal function is for ototoxicity. And so this is something that I will definitely keep in mind for some of my future patients, and to, if there are any signs of renal insufficiency in my patients, I would definitely want to bring them back for more frequent hearing tests, just to make sure that we are monitoring for any further changes in their thresholds. As for number 2, so looking at the age scale, both elderly and our pediatric patients that we'll see are reportedly more sensitive to cisplatin ototoxicity. And so that's something important for us to keep in mind again while we're seeing patients, is that our very young, adorable patients and again our very old, adorable patients, those are the ones that we're really going to want to watch to make sure that we are assessing to see if there are any elevations in their thresholds due to them taking cisplatin. And then third, the degree of hearing cell damage and hearing loss is directly proportional to the dose of the drug to which the outer hair cells were exposed to. And so with that, we know that the outer hair cells are the ones that are being damaged by the ototoxicity, and that the degree of the damage done to those outer hair cells is directly proportional to the dosage of the drugs that they're on. So that's important to keep in mind, that if we are starting to see some patients with some progressive hearing loss due to their chemotherapy regimen, that should be a red flag for us to reach out to their doctor and their oncologist to see if any sort of adjustments to their chemotherapy regimen can be made to kind of avoid any further loss at that time. And with that, these are my references, and I hope you learned a little bit about ototoxicity from my presentation. Thank you.